A quality minute with Copeeler. Today we're talking about partial CHG bathing as a tool for infection prevention. Spoiler alert, it does not round up. CHG, or chlorhexidine, is an antimicrobial antiseptic that we use to prevent healthcare-associated infections by daily application onto a patient's skin. We've had a big push to call this a treatment instead of a bath because we have a lot of patients that think baths are dumb. That's okay. I think cutting my toenails is dumb, but I still do it. If we rebrand CHG into a treatment, it's harder to refuse. Like, would they refuse a dose of their Zosyn for a day? Less likely. And we want to avoid refusals because the evidence supports CHG as a means to avoid multi-drug resistant organism acquisition, hospital-acquired bloodstream infection, and central line infections with daily administration. This is labor-intensive and requires a lot of intimate contact with a patient. Sometimes patients refuse. We can occasionally talk them into just wiping down their central line and insertion sites, and it makes us feel better. But is it actually avoiding risk? If you clean off the chest, is the patient going to almost immediately touch their crotch and then touch their line? Probably. The issue is that all the studies showing a benefit in CHG treatments look at total body wipe down, sparing the head. We know that this intervention leads to the desired outcome, which is CLABSI reduction. What I don't know is if a lesser intervention translates into the same outcome. It hasn't been studied. Application of this lesser intervention isn't evidence-based medicine. It's empathetic, biased manipulation. It may work, it may not. I just don't know and can't tell you that it's worth your effort. When you look into the literature for CHG, there is a lot of variation in results, with some studies showing no benefit at all. The issue is that the majority of studies on this topic do not look at CHG performance adherence to the approved administration procedure. In the studies that do, there's a more significant trend towards improved outcomes. A partial bath may be helpful, and it's probably better than nothing, but this is the one thing that we really tolerate partial credit for. Imagine only giving a patient half the dose of their other treatments. Imagine a patient refusing part of their treatment. Each of these areas should trigger escalation procedures, but with CHG, it's kind of like, whatever, the patient in 15 just pooped, I'm out. In this study about patient misconceptions around CHG bathing, we learned that patients take a lot of stake in what you say about their need for CHG. If you don't prioritize it and accept suboptimal application, your patients will deprioritize as well. So for nurses and techs, when charting CHG adherence, my recommendation for partial baths is to chart this like the patient did not get a bath at all. I would not round up. To me, a partial bath is the same as no bath for the purposes of quality improvement. You can see here the 5 pillars of a highly reliable organization, or HRO. In relation to charting partial baths, given the lack of data of benefit, it's important to highlight the miss so that we can develop countermeasures to address it. A unit with 100% CHG adherence via partial baths that's still having CLABSIs may float under the radar for improvement strategies and easy fixes. I would also say that in an HRO, a partial strategy is almost always trumped by a complete strategy. Partial baths will always be trumped by complete baths. But I acknowledge that on a given day, this might not always be possible. That's okay. Sometimes you gotta miss. But we should be investigating into the why behind the miss instead of providing half data like it's the full thing. For physicians and other providers listening, encourage your techs and your nurses. Ask your patients about their CHG treatments, question allergies, and discuss reluctance. If you care enough to ask every single day about their incentive spirometry, this is actually an intervention that actually makes a difference. In summary, I don't have data for partial baths being as effective as full baths. While we should be aiming for 100% adherence to bathing, this might not always be feasible. Focus on patients with central lines. In this situation, it's better to chart a miss than it is to round up. It allows us to analyze our data better, recognize problems, and develop solutions working as a team with nurses and techs. For docs listening to this, this is a team sport. Discuss adherence with your patients. Thanks for watching.